Okay, so this is our fourth installment of the MR Physics lecture series. This is a talk on artifacts. Now, I should just preface this by saying that there are lots of MR artifacts, and I'm obviously not going to cover them all. I'm going to cover the ones that I think are the most common / testable, and a few other ones that aren't mentioned in this talk are mentioned in other places in the lecture series. For example, some of the breast MR artifacts are mentioned in the breast MRI talk. Alright, so here's the first one. What we've got here is, this is taken from a pituitary protocol MRI. It's a narrow field of view, and it looks like that we've got part of the head sort of wrapping around on the other side. So this is called aliasing. It's an error of undersampling. Basically what happens is you get wrapping of the anatomy from the undersampled portions. Now notice that this occurs in the phase encoding direction. Now remember that phase encoding is a contributor to table time, so you always try to pick the thing that has the shorter dimensions, because that's going to matter. So if we look at a head, here's a nose. If you did slices in this direction, that would take you longer. There would be more of them than if you did slices in this direction. Alright, so this front to back is phase encoding direction this way. Alright, so we're seeing wrapping around occurring in that direction. So you can correct this by, one, increasing your field of view so that you're not undersampling, or you can change the direction, the phase encoding direction. Now, I should mention that for the purpose of multiple choice, there's two basic things you need to know about for every artifact that you see. First one is you should be able to recognize the named artifact. There's an artifact, and you have to know the vocabulary word that goes along with it. The next thing you need to know is if it's phase encoding, frequency encoding, or neither or both. And I will tell you that it's almost always phase encoding, so if you don't remember if you can't remember, just pick phase encoding. You'll be right like 95% of the time. The last thing to know is how to fix it. So that is a list of things to know. Now in my book, in the physics chapter, there is a chart at the end of the MRI artifacts section that has all the fixes, but you still have to be able to recognize the picture. But that is a chart worth memorizing for sure. That's very high yield. So here's the next one. I'm just going to review. This was mentioned in the liver lecture, and I'm just going to rehash it again because it's a good time to rehash it. There's two main types of artifacts related to fat. There's type 1, chemical shift, and then the type 2, which is the India ink or dark line. So let's talk about type 1 first. So you may remember that a gradient is used for localizing a particular voxel or a point in space, particularly so there's a phase encoding direction and a frequency encoding direction. We're going to talk about this frequency encoding direction first. So gradient is applied so you can tell things are in different locations. Remember this equation here? I think I talked about this in the very first lecture. This is your Larmor equation, where you've got frequency being determined by the field strength times some constant. And that constant is related to whatever it is that you're trying to image, hydrogen in most cases. Now, water and fat are different. They spin differently. They have different T1 relaxation times, and it has to do with, complex sort of organic chemistry stuff, electronegative oxygen pulling protective electron clouds away from the hydrogen nuclei, all that stuff. You don't need to know that. What you do need to know is that they're different, and that they rotate differently because of that. And if they have slightly different frequencies, then your ability to identify their exact location based on your frequency gradient or frequency encoding gradient is going to be just marginally off, something like this. And this is an artifact here. You notice that a little bit bright on one side and a little bit dark on the other. You'll notice that it is occurring in the frequency encoding direction. This is an exception to the rule that I mentioned in the prior case where I said everything's phase encoding, almost everything. This is when it's frequency encoding. So all this, you can see the artifacts here, white on one side, dark on the other. It's all in this direction. And by convention for abdominal imaging, so here's an abdomen, the phase encoding direction is this, because that's less cuts, and the frequency encoding direction is this, because it's more cuts. So that is the direction that you are, that is the frequency encoding direction. Now, obviously you can switch that, but by convention, for an abdomen, that's the direction it's going to be. So what makes it better? What makes it worse? Well, increase in field strength is going to amplify this difference. So that's going to make it worse, right? The second thing that's going to it's going to affect it is the receiver bandwidth. So I had this chart that I drew to try to understand this because I'm like a visual thinker. So we've got high and low bandwidths here. And here's our frequency up and down here, and this is our location. So a small difference in frequency is more noticeable at a low bandwidth, whereas a large difference in frequency, or small differences in frequency are less noticeable at a high bandwidth. In other words, this is a big change here, right? And this is a small change here. Yet we got the same difference here, the same distance here. In other words, differences in frequency are less noticeable with a high bandwidth. Because if we put the same distance down here on the low one, then we would have gotten them spaced out more. Does that make sense? So if we instead drew, and we had a big difference here, we came across, and this one we kept the same, we'd have one here and one there, and that would be a totally different location, right? Okay, so that's type 1. Now what about this type 2, this India ink? So the same general concept, you've got fat and water behaving differently, and so one is faster than the other. So as they process, you're going to have the water sort of taking the lead. It's the Kenyan runner versus the fat guy, and at a given time, which is 2.2 milliseconds on a 1.5 Tesla magnet, they're going to be directly opposed to each other, And as a result, they're going to cancel each other's signal out, and you're going to get this dark line or India ink artifact. And then they're going to continue moving, and at a certain time interval, which is 4.4 milliseconds on a 1.5 Tesla magnet, they're going to be in phase, and that artifact is not going to be present anymore. And then we're going to go around again here, and they will be out of phase again. India ink shows back up, and this continues forever. Every 2.2 seconds, they'll be in phase and then out of phase and then in phase and then out of phase and in phase and then out of phase, and it just has to do with their relationship to each other there. So, just recapping, type 1 artifact occurs in the frequency encoding direction, and it's worse with high field strength and a more narrow bandwidth. It's seen in both spin echo and gradient echo sequences, as that is not that doesn't have anything to do with it. Now, type 2 artifact, or this India ink artifact, is you see the signal drop out when they're directly opposed to each other. So at 2.2 seconds, and then again at 6.6 milliseconds on a 1.5 Tesla magnet. Now, you're going to see this with gradient only, and the reason is, remember, by definition, a spin echo has a 180-degree refocusing pulse. That redirects their relationship with each other. So you don't have them getting ahead and that kind of stuff. So that's a gradient thing only. All right, next case. We see this line over the spine, sort of looks like a syrinx, maybe. Well, zoom in. Right there it is. Notice that it's not present on the axial. So this is a type of artifact called Gibbs artifact. Also has another name called truncation artifact. Which name will they use? They will pick the one that you don't remember, so remember them both. You also see it here sometimes near interfaces, skull and brain interface here, these ripples. So the general idea is that we think about acquiring data in blocks, and blocks have sharp edges when you draw them like squares, but that's the ideal scenario, but that's not how it occurs in the real world. You've got ripples that are at these interfaces, especially at abrupt interfaces. They're much more noticeable. So if I had orange next to a slightly different shade of orange, you may not notice that as much as orange on red or red on yellow. So that's what causes this artifact. So you classically see this artifact occur at high contrast interfaces, like the cord and CSF. That's why you see it over the spine like that on a sagittal image. The skull and the brain interface, you can see it with meniscus next to fluid as well. That CSF cord interface is the most classic because it mimics pathology, it mimics a syrinx. If prompted, I would say the cause is limited sampling of free induction decay. That's what you actually read in physics books. It can be seen in both the frequency encoding and phase encoding direction, but it's more classically seen in the phase encoding because many times a phase encoding matrix is smaller than the readout matrix. Selected to, that's the one that's selected to reduce time. So, to improve it, you're going to want smaller pixel sizes, or you're going to want more matrix. Now, with a smaller pixel size, we're talking about more phase encoding steps, a smaller field of view. You can decrease the bandwidth. The payoff, or the penalty, for doing this is that obviously that takes longer, so table time, and then you're also getting, with a smaller pixel, you're reducing your signal to noise ratio. All right, so next artifact right here. Notice that there's 3 aortas and there should only be 1. So why does that happen? Why do you see this like pulsation artifact? It's sort of like a motion artifact. Like you can see it here also. You got a heart here and then you got another heart there. Notice that it's occurring in this direction, which we already said is by convention, the phase encoding direction in the abdomen. So, pulsation or motion can be voluntary or involuntary. Voluntary would be like breathing or moving, skeletal muscle moving. Or involuntary is, stuff like your aorta pulsating, your heart beating. It occurs in a phase encoding direction. Things you can do to make it better: you can yell at the patient to stop breathing. If this, let's say that there's a lesion in the liver and this thing is like projecting right over top of it, you can switch the phase encoding and frequency encoding directions to get that thing off the liver. Some people tell you can apply fat sat band like here, if that's moving up and down and causing a problem also. All right, so next one. We got 3 images of a sagittal knee. I'll just do a zoom up here on this tendon and make it big. Now notice that there's this high signal here on the gradient. You're seeing it also on T1, but it goes away on T2. This high signal is persisting, is probably real. This is artifact here. So this is one example. Here's another example. These are perineal tendons. Here's the distal fibula, just to orient you. So this is an MSK artifact. Notice that there's some high signal there. Oops. So this is an MSK artifact. You see it with tendons. And specifically, it occurs in sequences that have short echo times. T1 or proton density. Remember, T2 has a long echo time. And it occurs where you're at a 55-degree angle with the main magnetic field. So people will call this magic angle. It's actually better at a higher field strength because there's greater shortening of T2 relaxation times. So if you wanted to make it better, you could stick them in a bigger magnet, a more powerful magnet. But the real practical pearl is that you just check your T2 to see if it's real or not. So take-home points, long echo time goes away. You see it with short echo times. T2 is what you're going to use to verify if it's real or not. It should go away on T2. 55 degrees is the magic number for the magic angle, and a higher field strength will have less magic angle. All right, next artifact. See these lines here sort of running across here? This is a so-called zipper artifact. So remember that your RF pulses are basically radio waves. So if you've got a stray radio wave moving through there, you can end up with these zippers of high signal, like 1 to 2 pixels running across the image, typically in the phase encoding direction. So for the purpose of gamesmanship, the possible scenario is that anesthesia left the pulse ox monitor in the room, or somebody left a door open. So all electronic devices need to be out of zone 4, out of the room with the magnet. If that doesn't help, there's nothing in the room, you have to call tech people to repair the RF shielding. There should be RF shielding that keeps sort of stray radio waves out of there. All right, so this is this versus that, and what I'm showing here is same patient. He's got some metal in his knee. There's a T2 fat sat, and there's a stir. Now, we talked about stir in the previous lecture with regard to sequences and how stir works with an short inversion time that nulls the fat signal. But how does a conventional fat saturation work? So basically, you've got precession frequency of fat is a little bit different than water, and at a greater magnetic field, there's more and more difference there. It's actually easier to separate these peaks out at a higher field strength. But the difference between water and fat, at least at a 1.5 Tesla magnet, is about 220 hertz. So what you can do is you can place a saturation signal, a 90-degree pulse, or a pre-saturation pulse. You can apply it right at the precession frequency of fat, boom, to the entire field of view. And the excitation RF pulse is then applied to the slices, and the magnetic movements of the fat nuclei are flipped into saturation. So if they're flipped to 180 degrees, they don't have a component of transverse magnetization, and they produce no signal. Whereas the water can be excited and rephased and produce a signal. So you're hitting them, and then when you hit them again a second time, they're nulled instead of producing signal when you're ready to pick it up. So how you can get this screwed up is that if you've got some metal there, right, that's sort of like a magnet inside of a magnet, and that messes with the homogeneous nature of the field, and that is required to predict where this pulse is. So you miss the pulse because that local field is not homogeneous. So if you've got metal right next to it, it's missing the fat right next to that area. So that's why metal is more susceptible to creating inhomogeneous fat saturation with this type of technique. Now you can get a little bit of mess up with stir, but it's not nearly as bad. So if we go back, look at the case, there's a little bit right here, you know what I mean, like this, but it's a pretty big difference, right? I mean, just a little bit of signal here, right? But it's a big difference. So stir is much more durable with regard to dealing with metal and this local field, inhomogeneous local field, relative to the conventional fat saturation tactics. So sort of on that same theme, let's talk about susceptibility, which is this idea that you've got something that's creating an inhomogeneous local field. Point out that here we've got out-of-phase imaging, which, remember, that occurs first, and then in-phase imaging, which occurs second, and then out-of-phase, and then in-phase. But if we're starting at time point 1, this, and then this, right? 2.2 milliseconds, 4.4 milliseconds here. And notice that as time progressed, the gas that was in bow started causing a problem here. So the longer your TE is, the more susceptible you are to these things. So like the longer you go in time with your TE, the more and more and more you'll notice that this susceptibility artifact occurs. So here's another example. We've got gallbladder clips, and this is like time point 1 here, opposed, and then India ink artifact, and then here's time point 2, so this is 2.2 seconds, this is 4.4. Notice that it's blooming more and more and more, so that will just get progressively worse with the longer the TE. just some general concepts, testable, of course, with regard to susceptibility. So everything is susceptible. I mean, spin echo and gradient echo both are vulnerable to this. But it's much worse with gradient echo because it doesn't have that 180-degree refocusing pulse that defines the spin echo sequence. You see it at tissue, abrupt tissue interfaces. An example would be, the skull and the sinuses. And a way to make it better is, if you have the choice, use a spin echo sequence instead of gradient echo. You can use a wider receiver bandwidth. That's something you often see people try. And then you can attempt to align the longitudinal axis of the metal implant with the axis of the magnetic field. I think that's a little tricky. These are the two I would remember. All right, in next case, we've got sort of, I'll tell you that this patient has a lot of ascites. It's difficult to you can see a little bit of fluid signal here, right? But just take my word for it, there's a lot of ascites in this patient, and we're getting a big black blob void of signal right in the middle. So why does this happen? Basically, you have local eddy currents that are occurring in tissue. And the more tissue you've got, the more significant these become. So big body parts, the biggest would be the abdomen, especially in a big fat person, with ascites, you start to see this dielectric effect. It targets the center of the field of view, and it's more significant at higher field strengths. So things you can do to make it better are you can use a weaker magnet, or they make these things that are dielectric pads that supposedly compensate for this, and you can place it between the patient and the anterior body array coil. All right, so that's it. Those are the main artifacts that I think are testable. Like I said, in the MR breast lecture, I mentioned a couple that are breast specific. Okay,